motility disorders, including esophageal motility disorders and gastroparesis, which is what we're going to hear about today, as well as GERD and functional GI disorders. She earned her BA from UC Berkeley, and then she did the medical training at UCSF, her MD, her residency in internal medicine, GI fellowship, and then advanced transplant hepatology fellowship. She belongs to the American College of Gastroenterology, American Gastroenterological Association, and the American Neurogastroenterology and Motility Society, and she'll tell us today about gastroparesis and common mimics. So thanks for being here. We're excited to hear you.
Thank you so much, Alejandro, for the introduction. Sorry, my cat is jumping in and out of my screen. Just like Alejandro mentioned, so today I really wanted to kind of broadly cover, give an overview over gastroparesis, as well as touch upon some of the very common mimics to be aware of when considering a diagnosis of gastroparesis. So here are my objectives. Again, so we'll kind of discuss the how to diagnose and manage gastroparesis. And then really, I wanted to highlight some of the common pitfalls that I've seen in taking care of these patients with gastroparesis. And then lastly, review the mimics of gastroparesis, as I mentioned. So why care about gastroparesis? Commonly it's thought to be a very rare or, uncommonly something that we don't commonly see in the GI clinic, but gastroparesis rates are on the rise. So on the left here, so this is a study that used data from the Healthcare Cost and Utilization Project with nationwide inpatient sample, or the NIS. And this represents a nationally representative sample of about 5 to 8 million hospitalizations each year. And so, this is a slightly older study looking at data now from 1995 to 2004. But during that period, they found that the trends in hospitalizations for with gastroparesis as a primary diagnosis, when compared to other common upper GI disorders that we see, has really risen dramatically in that time period. So from 4,000 hospitalizations in 1995 now to 11,000 in 2004. And then looking at kind of subsequent years, so this is a study that looked at gastroparesis-related ED visits, again using a national database looking at 2006 now to 2013. And similarly, in contrast to other, again, common upper GI-related disorders, such as GERD or ulcers, they found that, again, gastroparesis is dramatically increased here. So from about 15,000 cases or visits per year now to almost 37,000 visits per year in 2013. So why is it we're seeing that this change or increase in rates of gastroparesis now? A couple of possibilities here. One, we know unfortunately that for this disease there's no cure, and this is a chronic disorder, so patients are kind of accruing in numbers without the option, without the possibility of a cure at this point. And secondly, there's probably increased awareness among both patients as well as physicians. So this is leading to an increasing number of patients who are getting diagnosed each year as well. There is also a rise in diabetes. And so we know diabetic gastroparesis is one of the most common etiologies, which we'll touch upon. And again, with rising rates of diabetes in the country, there's probably also leading to more patients developing diabetic-related gastroparesis. And then there's probably, a few other possibilities in terms of increasing surgeries, so leading to kind of surgical complications with gastroparesis, as well as increased use of medications associated with gastroparesis. So in particular with the GLP-1 agonists that we all kind of commonly know about and see is probably leading to this rise as well. So what are the common etiologies for gastroparesis? So this is just a table that lists it. By far and away, actually, idiopathic is the most common cause. So about studies kind of quote about 30 to 50% of patients probably have are diagnosed with idiopathic gastroparesis. Although the suspicion is that there may have been some sort of infection or inflammatory related cause that just was unknown. And then the second, probably most common, is diabetic gastroparesis, and this accounts for probably about 25 to 30% of cases. Following subsequent to that is probably medication related. So probably about 20% of cases are medication related. And again, this could be due to opiates, could be due to medications like GLP-1 agonists or anticholinergics. So something to keep in mind. And then also, as I mentioned, surgical related gastroparesis is very common. So any surgeries that may involve either a partial or complete vagotomy, which we used more commonly in the past and not so much anymore, as well as what we see here, patients in lung transplant. So definitely had some referrals for these. This can be a known and common adverse event after transplant. Other less common causes may include connective tissue disorders, vascular disorders, neurologic disorders, infiltrative, as well as malignancy and radiation. But these are probably more rare. So just to kind of review for us how the gastric motility or normal gastric motility works. So the stomach is divided, as we all know, from the kind of more proximal to the distal portions. So starting the proximal, there's the fundus, followed by the body, the antrum, the pylorus, and then this connects to the duodenum. So the purpose of the fundus here, it's really serves as a reservoir for the stomach. And it's also considered to help regulate the liquid emptying and plays a role during the meal to kind of accommodate and relax. So it allows the meal to kind of sit in the stomach. We think this is mediated by inhibitory neurons in the enteric nervous system. And when there's a defect here in an accommodation, oftentimes this can lead to the symptoms of early satiety. So next we have the gastric body. And so this is where we know the main pacemaker of the stomach is located. So these are the interstitial cells of Cajal. And they initiate the slow wave activity, which then regulates the rest of the motility of the stomach and kind of sets that cycle, sets the gastric motility at the 3 cycles per minute that we know. And so we know that any gastric dysrhythmias oftentimes can contribute to kind of symptoms of nausea as well. Then we have the antrum here. And so the antrum is where the more muscular part of the stomach is located. And so this is the area of the stomach, which is responsible for kind of the mixing and grinding of the food. And this takes place, in order to make chyme, which then can pass through in the intestine. It's important here because in order for the chyme to pass through the pylorus, which is that muscular sphincter, it has to be a certain millimeter in size, so less than 2 millimeters in size in order for this to occur. And so after a meal, or I should say, so after we eat, so during, kind of that mealtime, the pylorus here has to contract in order to allow this grinding activity to take place in the antrum. And so when there's impairment of either the electrical mechanical activity of the antrum, as well as any reduction in the pylorus sensibility or cross-section area, this can all lead to delayed gastric emptying. And then lastly, there's also a very important coordination between the antrum and the duodenum. And so kind of how we talk about defecatory disorders and pelvic floor dyssynergia with that kind of complex interplay of coordination of the muscles, I kind of think of that similarly. So between these 2 segments of the gut, there's this highly coordinated motion between them that has to regulate the rate of emptying of the stomach into the intestine. So let's move on to kind of how do we define gastroparesis. So really, this is a syndrome of cardinal symptoms, including nausea, vomiting, early satiety, postprandial fullness, and then also can include epigastric pain, bloating, weight loss, as well as the objective delay in gastric emptying. And then thirdly, there has to be evidence of, or I should say, absence of mechanical obstruction. So we really have to rule out any underlying mechanical obstruction, and that can be done by various studies. I also wanted to touch upon here functional dyspepsia. And there's been a lot of talk recently in terms of kind of with gastroparesis and functional dyspepsia, really being more on a spectrum of disorders. And so kind of thinking of them in similar, and I'll go into kind of why we commonly think about this, mainly based on the symptoms that they both can present, but they're very similar. And so in terms of functional dyspepsia, how do we diagnose this? So this is based on the Rome 4 diagnostic criteria. And so this requires at least one of the following symptoms. So either bothersome postprandial fullness, bothersome early satiety, bothersome epigastric pain, or bothersome epigastric burning. Similar to gastroparesis, there has to be no evidence of any underlying structural disease. So typically this can be done again with like an endoscopy to explain the symptoms. And all these criteria have to be fulfilled for at least the 3 months preceding, with symptom onset at least 6 months before the time of diagnosis. And so here, this is just a study looking at patients with functional dyspepsia and when they're given a standard test meal. And this kind of highlights, how we really can kind of classify functional dyspepsia into 2 groups. So here on the y-axis, there's a symptom score, and the higher the score, means that they're more symptomatic. And so what they found that in functional dyspepsia patients, there were really, again, these kind of 2 groups of patients. So in patients with symptoms that were more kind of meal related, so here, you notice that the patients had worsening symptoms within about 30 minutes after eating a meal. And this can be, again, a number of symptoms, such as like the fullness, bloating, nausea, or pain, in particular, fullness and bloating as well. And then there's another group of patients here with symptoms that are really not so much meal related. They can often get some symptoms that are worse after meals, but again, not as significant as the other group. And you'll notice that in the group of patients with symptoms that are meal unrelated, the predominant symptom here is really epigastric pain, as opposed to kind of more of the fullness or bloating. And so because of this, we can classify functional dyspepsia into kind of 2 subtypes. So the first subtype I think of is the postprandial distress syndrome here. And this is really characterized, again, by more the bothersome postprandial fullness, as well as the early satiety. And so this differs from the other subtype, so the epigastric pain syndrome, which is really more characterized by bothersome epigastric pain or burning. So again, why do I bring up functional dyspepsia when I'm talking about gastroparesis? So we can kind of see from, the last few slides that really patients with functional dyspepsia and gastroparesis share a lot of the same symptoms. So in particular, abdominal pain, early satiety, and bloating can be, very commonly seen in both of these diseases, whereas nausea, vomiting, loss of appetite, weight loss, and malnutrition is really more prevalent, I would say, in gastroparesis and less commonly seen in patients with functional dyspepsia. But this overlap is highlighted really nicely by this recent study from the Gastroparesis Consortium. And so here, they measured the gastric emptying of all patients at entry to the study, and then 1 year later. And they found that on average, about 40% of patients would flip from one group to the other. So here, as many as 42% of patients with gastroparesis would change to then be classified with functional dyspepsia based on the gastric emptying. And 37% of patients with functional dyspepsia would also change over to the meet criteria for gastroparesis at that 1 year mark. However, you'll see that despite this change in gastric emptying, this really actually didn't correlate with any change in their symptoms based on the GCSI score for these 2 groups. So what does this mean? I think, again, this highlights that there's probably a lot of overlap between functional dyspepsia and probably more likely mild cases or of gastroparesis. And because of this, I oftentimes think of treating these patients very similarly. And then also just kind of keeping in mind that patients can fluctuate between, a diagnosis of functional dyspepsia and gastroparesis. And again, that they probably exist more on a spectrum. So how do we go about diagnosing and working or evaluating a patient for gastroparesis? So this really starts off with, making sure that we take a very careful and thorough history and physical. I oftentimes really like to ask about any childhood GI symptoms that, oftentimes these patients get diagnosed very late. So on average can take 5 to 7 years after onset of symptoms before they get diagnosed. So kind of always thinking back to see if they might have had any preceding types of symptoms. Also, asking about any possible triggers before the symptom onset, thinking about, again, maybe there was some underlying infection or etiology that might have led to the development of the gastroparesis. And then on physical exam, we classically think of a succussion splash being able to be auscultated during your abdominal exam. In terms of labs, really not much needs to be done. I order just kind of basic labs. They haven't had them done recently, so just kind of checking CBC, electrolytes and CMP, just to make sure that there are no severe derangements. I don't typically check a lipase, and this is not recommended in the guidelines either, unless there is some known risk factors for pancreatitis. And similarly, routine celiac labs are not generally recommended in the guidelines, unless again, there's some other suspicion. Most of these patients will undergo upper endoscopy. And again, this is to rule out some sort of mechanical obstruction that might lead to the symptoms. Oftentimes we'll get gastric biopsies, and this is to rule out underlying H. pylori. And you can also obtain duodenum biopsies if there is some clinical suspicion for possible inflammatory conditions such as celiac disease or eosinophilic gastroenteritis. And then lastly, again, we need some sort of objective measure of delayed gastric emptying. So there's a few different options here. And keep in mind that I don't order this for all patients that I see with these types of symptoms. It's really only if there's a strong suspicion for delayed gastric emptying that you want to order these studies. And so being mindful and being somewhat selective. So I'd say the one that's usually done, is considered the gold standard, is really our gastric emptying scintigraphy study. Ideally, this should be a 4-hour study. You will see that there are cutoffs for as short as a 2-hour study. So technically, if there's greater than 60% retention of the gastric activity at 2 hours, that could be classified as gastroparesis. But it really the gold standard, and you'll see that in studies, they stress that you want to make sure you have a full 4-hour study. And the diagnostic criteria would be at least 10%, greater than 10% retention, gastric retention at 4 hours. And if you have a study that's kind of shorter than 4 hours, to really maybe reconsider or repeating the study. Some other options that are also available are the wireless motility capsule, which measures the motility of the entire gut. And the cutoff of the stomach specifically is 5 hours. I mentioned this only because it used to be available, I guess. It's now no longer available in this past year. It's no longer on the market. But in general, I think there's a little bit of hesitancy with using this test anyway, just because people feel this is not really a true physiologic test, since you're consuming, a capsule that's non-degradable, and so does it really reflect the true emptying of the stomach versus, when you're eating a meal. And then more recently, this test became available. So this is a carbon-13 spirulina breath test. Still mostly used in the research setting, although now actually the company can mail the tests out to patients' homes. And so they actually have the availability or the option to be able to perform the test at home. And the results are actually quite reliable with a very good correlation with scintigraphy. And how this works is that patients fast for a period of time similar to when they do the scintigraphy, and then they eat a meal that's labeled with carbon-13. And then they have to exhale into these bags to measure the carbon levels within the breath at different time points. So next, just wanted to talk about kind of giving a broad overview of the treatment of gastroparesis. And then I'll try to highlight some more of the, kind of more of the critical pieces I find when I kind of go over some of the mistakes and pitfalls that I've seen in managing the gastroparesis. So to start, we always recommend diet and lifestyle changes. And this is more, I would say, for patients with mild gastroparesis, although it should be, all patients with gastroparesis should be educated about this. And so the teaching is, rather than having 3 large meals, having these more frequent, maybe like 6 smaller meals throughout the day. We also want to teach that avoidance of high-fat foods, because those are the high-fat foods tend to slow the gastric motility and gastric emptying as well. And then waiting about 3 to 4 hours after a meal before lying down can also help with symptoms. The next approach I have in terms of use of medications, I try to target based on the most bothersome symptom that the patient's kind of presenting with. And so for nausea, let's say, So again, this is, might be an issue with the electroactivity within the stomach. There's a lot of different antiemetic agents, options. So I won't go into all the details about them. But again, I'm sure you're familiar with ondansetron, compasine, Phenergan, metoclopramide, and domperidone are also technically antiemetic agents, as well as aprepitant. And then if you're really trying to target more symptoms related to, you think, delayed gastric emptying, then I would probably favor using a prokinetic agent here. So the only FDA-approved medication we have available for gastroparesis is actually metoclopramide. There's also domperidone, which is not available in the US unless it's under IND, but can be purchased through the Canadian pharmacies. Is usually how we are able to obtain this. And then there are a few other prokinetic medications, such as erythromycin and the prucalopride, which we'll touch a little bit more upon, and then pyridostigmine as well. So next, if you're thinking about symptoms kind of more related to like early satiety or kind of that postprandial fullness and nausea, I might think about then more medications that really help the fundus relaxation. So these are neuromodulators such as buspirone and mirtazapine, which I'm big fans of, as well as aprepitant has some data to suggest that it also increases fundic relaxation. And then the prokinetic agents also can work similarly for these symptoms. And then lastly, abdominal pain. This is actually not something that's highlighted, or necessarily included as a recommendation in the guidelines. But I do find that many of these patients do have abdominal pain, and something that is probably underdiagnosed and undertreated. And so classically, we think of antidepressants, in particular, the TCAs really have the best data for treatment of the abdominal pain. We think related to, likely some visceral hypersensitivity going on. But you can also consider SNRIs and SSRIs as well. And then moving on to some of the non-pharmacologic therapies. Again, there's been a lot of interest in particular in GPOM in the last few years, as well as gastric electric stimulation. There's also Botox injections, although again, in the guidelines, this is actually not recommended based on some small RCT trials that showed no benefit or no improvement in symptoms. And then you can always consider more invasive or other invasive strategies such as surgery or a G-shaped tube feeding if necessary. So this is just to really highlight that the last few years, both the AGA and this ACG provided updated clinical practice guidelines. I present this here not to necessarily for us to go through, but really just to for you to be aware of, and so just as a reference. And then also just to highlight here that for both of these practice updates and guidelines, it's really based on expert opinion and consensus. Just because when they were reviewing the existing literature, a lot of the studies were kind of very small, lower in quality. And so this is not technically a systematic review. And so they're not able to actually provide formal ratings in terms of the quality of the evidence and strength of recommendation. So just keep in mind, these are really more expert opinions. And then I did want to go over again, the one FDA-approved medication that we have available for gastroparesis is metoclopramide or Reglan. So how this works, so this is a dopamine receptor antagonist. It does cross the blood-brain barrier, and this is as opposed to domperidone, which doesn't. And because of this, there are several CNS side effects that are really common. So you may think of like agitation, restlessness, as being kind of common side effects. I think up to like a third of patients will probably experience those. And then also to be aware of, so in 2009, there was a black box warning that was placed for tardive dyskinesia. So because of this, the recommendation is to limit treatment duration only to 12 weeks, although I have many patients that are on this for much longer periods of time, and chronically, without development of tardive dyskinesia. And just to kind of highlight, I think in the past we were, especially after 2009, there was a lot of hesitancy around, prescribing this medication because of that concern and risk for tardive dyskinesia. But probably, I think the older studies, reported as high as, 1 to 15% of patients may develop tardive dyskinesia, which is probably much higher than it was in reality. And so this more recent abstract that was presented at DDW in 2022 now found that the incidence of tardive dyskinesia really in patients with gastroparesis versus the general population was quite similar. So in the general population, they found that those who were on metoclopramide for other reasons, the incidence was about 0.03% versus those with gastroparesis on metoclopramide. And again, it was about 0.1%, so 1 in 1,000. And that the risk of the tardive dyskinesia increases with certain risk factors. So older age, female sex, renal dysfunction, mental health disorders, use of other dopamine receptor blocking agents, diabetes, and longer duration of use again. So just to kind of keep this in mind. And then also, lastly, just to mention that in 2022, the FDA did approve a nasal spray formulation of the metoclopramide, which is really nice. When thinking patients are, again, you can use this as an antiemetic option. And so if patients are kind of having a really severe flare-up of their symptoms and not really able to take, an oral medication, then the nasal spray is a really nice option for them. So moving on, just wanted to kind of cover again some of the really common pitfalls that I've seen in taking care of these patients, and hopefully, this will kind of bring up some really good practice points just to kind of keep in mind when you're taking care of folks with gastroparesis. So I kind of touched upon this already, but really, again, coming back to the diagnosis of gastroparesis, making sure that you're basing this off of a good high quality study. And so some of the issues here is that, assuming, delayed gastric emptying, or if that a gastric emptying study, meeting criteria for delayed gastric emptying is diagnostic of gastroparesis. So really, again, keep in mind that the gastroparesis is a syndrome. So you have to, have that objective criteria of the delayed gastric emptying, but it also needs to be in a patient who has symptoms that are consistent and suggestive of gastroparesis. So if you're just looking at, if you just have a study in isolation, I wouldn't say this person is diagnosed with gastroparesis. I would just say they have delayed gastric emptying. If they don't also have the symptoms at the same time. Another common referral I'll see is that patients who underwent an EGD and they happen to have delayed gastric emptying or signs to suggest that delayed gastric emptying with findings of food in the stomach, and then they're just diagnosed with gastroparesis, then kind of sent over for management here. So I've seen this a number of times, and they don't actually have any sort of, again, objective data to support the delayed gastric emptying diagnosis. While there is some correlation with finding of gastric contents or solid food, in particular in the stomach, the positive predictive rate is probably about 50 to 55%. And it is actually higher in patients who, when they looked at studies with patients with diabetes, and so may actually have, a true risk factor for development of gastroparesis. But again, just kind of knowing this, that just because you have a finding of food in the stomach during EGD, despite fasting, this is not diagnostic of gastroparesis. And then again, keeping in mind that there are kind of studies and how the gastric emptying studies are performed is really important in terms of kind of assessing the accuracy. And so this is just a table that highlights some of the criteria in terms of how to ensure a reliable gastric emptying study is performed. So a couple things here is really making sure that they've stopped medications that may impair gastric emptying prior to the study, which actually, sorry, is not included here. But things like medications like opiates, again, anticholinergic agents, these all need to be stopped beforehand. Otherwise, of course, you're going to see gastric emptying delay related to those medications, making sure the patient's fasting beforehand as well. And then being consistent in terms of the types of meal that they're using. So they don't always report this in the study, but it is something important to note that it should be a standardized test meal using a low-fat substance. Usually the most common one is egg whites that we'll use here at Easy Stuff, but making sure that they have the standard meal. Because again, the gastric emptying can differ depending on what the person's consuming. So another common pitfall is failing to investigate biopsychosocial factors in patients with gastroparesis. And so it's really important that, again, patients with gastroparesis, that there's not really a good correlation between the severity of the symptoms and actually their severity of the disease, which is kind of highlighted here in this study where they looked at patients with gastric emptying that were considered to be normal with a normal gastric emptying time versus those who had an abnormal. And they found really that in patients who were reporting symptoms, suggestive gastroparesis or functional dyspepsia, there is really kind of similar rates in both groups. And so this has kind of been demonstrated in other studies as well. So we know that the gastric emptying delay, or the severity, I should say, the gastric emptying delay does not always correlate with their symptoms. And so because of this, always keep in mind there may be other contributing factors to why patients may have more severe symptoms. Commonly, this could be related to maybe some underlying mental health disease, stress, poor sleep, low mood. And so kind of taking into account these other psychosocial factors and always thinking, how do we address those other important roles that they may play? So maybe considering the role of neuromodulators and how that may be able to benefit the in treatment as well. So ineffectively addressing nutritional issues in patients' gastroparesis. So we really wanted to highlight here the importance of the small particle diet when making recommendations on how, in terms of how to kind of alter their diet modification for patients. We're traditionally taught that foods really high in fat as well as high in fiber delay stomach emptying, but it's not so much the fiber that is actually an issue, it's more so the particle size. And so this was a nice study that found that compared patients who were recommended a standard gastroparesis diet. So again, that kind of low fiber, low fat, low glycemic content versus those who are just recommended a small particle diet. And so what does that mean? It just means foods that can be easily mashed with a fork, like mashed potatoes, scrambled eggs, those kind of things. And so in this small RCT, they found that a small particle diet was associated actually with an improvement in the symptoms of nausea, vomiting, early satiety, postprandial fullness, heartburn, and regurgitation, compared to the standard gastroparesis diet, which really didn't see this effect. And when available, I always love to involve a nutritionist to kind of help counsel these patients and again provide a lot more guidance. Another common issue can be, some of these patients can really develop a lot of weight loss and malnutrition as a result of their symptoms. And so again, nutritionists can be really helpful to kind of assess for that if it's a concern. And then also kind of keeping in mind, some patients with avoidant restrictive food intake disorder symptoms can have very similar symptoms to patients with gastroparesis, and to kind of also consider whether there may be an underlying eating disorder at play here too. So not optimizing medications for gastroparesis. Really, this is, I've had so many patients tell me, oh, I tried domperidone or I tried metoclopramide, and it didn't work for me. And when I asked or a little bit more questions as to how do they use the medication, either they didn't really time it correctly, or they just tried it once or twice and they said it just didn't work for me. So in terms of timing, you really want to time it for before eating, as since oftentimes symptoms worsen or are triggered by meals, and so telling people or counseling patients to try to take it about 30 minutes before they anticipate they're going to eat, so that the prokinetics have time to actually induce gastric motility. So just kind of providing some education. And then also really screening patients and treating for aggressively any underlying constipation. And so this was a nice study that was done, I think, in 2019 now, where they looked at prucalipide. That is FDA approved for patients with chronic idiopathic constipation, so not technically patients with gastroparesis, but this was a study where they looked at patients with gastroparesis and then given prucalipide. And they did find that prucalipide versus placebo did improve gastric emptying, and also led to a reduction in many of the symptoms related to their gastroparesis, as well as improvement in quality of life. And so prucalipide is one I actually really commonly prescribe, especially if there's any underlying constipation, and find that can be really helpful for a lot of folks. Next is ignoring the roles of drugs, such as opiates in generating symptoms. So I think I touched upon this a little bit already, but I can't count the number of patients that have been referred to see me for gastroparesis and were either on chronic opiates or on taking opiates pretty frequently on an as-needed basis. I'd probably say at least 50 to maybe 75% of the patients I see are on opiates at the time of the referral. So we're kind of all probably already aware of this. So I don't really need to hone or hammer this in so much, but we are aware that opiates cause delayed gastric emptying. And so when they have patients with symptoms of gastroparesis, we know that opiates are working. And so this is just a study here that looked at in patients who were on chronic opiates versus compared to those who are not on chronic opiates, that the comparison of symptoms was in patients with gastroparesis was significantly worse for most symptoms when they were on chronic opiates versus those who are not on chronic opiates. And then also just keeping in mind other medications that can also be associated with delayed gastric emptying, other than classically we think of opiates, can also include anticholinergics. So thinking of like bentyl, hyoscine, and then antipsychotics is another really common one that I see. And then again, GLP-1 agonists, which I think we're all really aware of in terms of its impact on the gastric emptying. So overlooking the role of GERD. So patients with gastroparesis, have a failure of emptying their stomach. And so as a result, this does lead to increased regurgitation of acids and non-acidic content into the esophagus. And so really, really, really common for patients with gastroparesis to also have coexisting GERD. And so just kind of keeping in mind that the GERD could also be worsening some of their symptoms, in particular regurgitation, nausea, vomiting. And so just treating GERD when you just thinking about, treating GERD in all its patients as well. Failing to address poorly controlled blood glucose levels in patients with diabetic gastroparesis. So again, I also can't count the number of times I've seen referrals for patients with gastroparesis and their A1C is like 12 or 14. And so again, many studies have shown that when patients have frequent hyperglycemic states, that is very highly correlated with worsening or delayed gastric emptying. So again, not something I need to, I think, hammer in as much here, but this was a small study that looked at whether the effect of continuous glucose monitoring, as well as treatment with continuous acute insulin infusion, had an impact on gastroparesis symptoms. They did find that when patients were with diabetes or diabetic gastroparesis did receive kind of this more continuous therapy and thinking that they probably had kind of more even and stable glycemic control throughout the day, this did lead to significant improvement in their GCSI scores. So the next pitfall is, really that a common mistake I see is thinking that abdominal pain is actually uncommon in patients with gastroparesis. But I would, in studies, it's probably reported that about 90% of patients probably have some degree of abdominal pain, and it is technically one of the cardinal symptoms of gastroparesis. And most commonly presents, in the epigastric area. And so just kind of keeping that in mind, but also making the assumption that either abdominal pain will be treated or improved if we simply speed up the gastric emptying. And again, just to highlight, there really hasn't been any studies that support this correlation, that the severity of the abdominal pain correlates with the severity of the gastric emptying. And so despite, certainly we can try prokinetic agents to see if that does help with the symptoms, but I find more often than not, when pain related specifically, they often respond better to kind of more than neuromodulators. And so probably suspecting that there's maybe some underlying either psychosocial stressors or visceral hypersensitivity that might be contributing to their symptoms too. And then lastly, so another common pitfall I've seen is not selecting patients really appropriately for kind of more invasive therapies. So kind of those non-pharmacologic therapies. And so, some of the ones that we think of is gastric electric stimulators, which we don't actually do at UCSF, but, you can refer patients to Stanford or CMPFC for consideration. And so the studies really have been mixed in terms of the results here. And I would say probably more consistently, has been demonstrated specifically in patients with diabetic gastroparesis, but really for refractory vomiting symptoms specifically. So has not been well demonstrated to really improve the other symptoms, like in particular pain. So if that is the predominant symptom, I'd be a little hesitant to refer a patient for gastric pacing in that setting. And then again, just to highlight, technically Botox injection is not recommended in the guidelines. And this is again based on 2 very small RCTs that found that the intrapyloric Botox injection versus sham did not lead to any improvement in symptoms. But I do think there is a clinical role for a Botox injection, and that it can be very helpful in selecting or identifying patients who might respond really well to GPOM, actually. So more recent data has been suggestive of that. The other thing just to highlight in GPOM, again, something very exciting that we now have available with at UCSF with Abdul Kwanda performing several already. But I think really just to highlight, again, being very selective as to who is going to best respond or best benefit from undergoing GPOM. So there was this study that was done now in 2022 that developed what they call the GPOM predictive score. And this is based on subscales of the GCSI, as well as the severity of retention on the gastric emptying scintigraphy. And so they assigned a score based on these different scales, and they found that patients who had a score of 2 or higher were much more likely to benefit or have a positive response to GPOM, so 80%, versus patients who had a score of 0 or 1, which were only likely to have an 18% improvement in their symptoms after GPOM. And then kind of moving on into, the last pitfall or common mistake is really, again, not considering conditions that can commonly mimic gastroparesis. So this is just a list of common conditions to think about. And again, I'll just kind of highlight a few in the next few slides. So one I wanted to talk about is cyclic vomiting syndrome. So this is a chronic disorder of the gut-brain interaction that's being increasingly recognized in adults. It was always pretty well known in the pediatric population, but I think more recently is now being recognized in adults. And this is really characterized by the episodic symptoms of nausea and vomiting predominantly. Prevalence is probably about 2% in adults, so not insignificant. This is kind of on the similar order as patients with celiac disease or even Crohn's disease. And then again, there is some overlap with cannabinoid hyperemesis syndrome, which I'll kind of also touch upon a little bit later. So cyclic vomiting syndrome is really commonly associated with a number of other diseases. So in particular, there's a really common prevalence in these patients for having migraine headaches, IBS, headaches in general, and then also they tend to have a strong family history of headaches, migraine headaches, as well as IBS. So something I always ask about as well. And then also keeping in mind, there is also a high association with other psychiatric comorbidities in patients, which can certainly kind of play into their symptoms as well. So as high as 70% patients may have underlying anxiety as well as panic disorders, and then almost 50% of patients probably have some underlying depression as well. So how do we diagnose cyclic vomiting syndrome? Again, this is based on the Rome-4 criteria. So in the preceding 3 months, they had to have all of these symptoms. So 1, stereotypical episodes of vomiting with the kind of really acute onset of the symptoms and a duration of less than a week. They had to have at least 3 discrete episodes in the prior year with at least 2 episodes in the last 6 months. And these have to occur at least 1 week apart. And then again, the really key here, I find, in diagnosing, distinguishing these patients from other disorders is the absence of symptoms, really, in particular, like the nausea and vomiting, or just having really mild symptoms in between these episodes. And so here, again, kind of thinking about really these cyclic episodes of their symptoms. And so anytime I hear a patient saying, oh, I have like a really severe flare of nausea and vomiting that occurs maybe like once a month or once every couple months, that usually is a key in my history to thinking about whether this person may have cyclic vomiting syndrome. Technically, there really aren't any confirmatory tests. And again, routine gastric emptying study is not really recommended in this setting just because the symptoms aren't, are really episodic and so not quite consistent with gastroparesis. So I oftentimes don't order actually a gastric emptying study for these patients. So the typical course you'll think of is, again, so highlighting that in this kind of in between the episodes, people are generally feeling pretty well, and they have really absent or minimal symptoms. And then oftentimes, about 90% of patients, they may have this prodromal phase. So it's kind of similar to how we think about with migraine headaches. There can be a lot of different symptoms. Sometimes it's nausea, abdominal pain, but themes kind of like more vague, like just fatigue or even panic or fear. This can last kind of anywhere from 30 to 90 minutes. And most episodes can occur kind of without warning, but sometimes there are some triggers for folks. And this is really the time for when you want to kind of educate people to use their abortive therapies that we'll kind of go into. So really the most common one being the triptans as well as their antiemetics. Kind of during the episode or kind of the emetic phase, this is really highlighted by kind of that intractable vomiting, retching, nausea, kind of abdominal pain. Oftentimes people say they are not able to tolerate or kind of keep down any fluids or any foods or medications even. And during this period, it's really kind of supportive treatment. So kind of giving them antiemetics as possible. Oftentimes usually requires IV, and then putting them kind of in a quiet, dark room. This is to really induce sleep, essentially, kind of similar to how we manage headaches or migraines. And then next, they kind of move on to the recovery phase. So, now they're able to start to kind of take in more PO at this point and kind of return to their normal daily activities. So I won't go through this in much detail in terms of kind of the diagnosis and treatment of cyclic vomiting syndrome. But again, this is a really nice review that just came out last year in gastroenterology, and then kind of characterizes patients either as having mild versus moderate or more severe cyclic vomiting syndrome. And the reason why this is important is that in the more mild, so this is kind of determined by how frequent the episodes, so kind of maybe just a few episodes per year, and the episodes lasting maybe just for a day or two with a pretty quick recovery in between the episodes, and rarely having to go to the emergency room or the hospital. And these patients, you can probably just consider providing them with some sort of abortive treatment. Whereas in the more moderate to severe category, so these are patients who are having maybe monthly episodes, so much more frequent. The episodes may last longer, so several days up to a week. And again, they have this long recovery and frequently having to go to the emergency room or get hospitalized. These are the patients that, in addition to providing them with abortive therapies, you also really want to think about starting them on some prophylactic therapy as well. So again, this is from that same review article. There are lots of abortive therapies that are as options here. So just to highlight, the one that I prescribe by far most commonly is really the triptans. And this is considered kind of first line use. The nice thing I like about, in particular, sumatriptan is that there is a intranasal form, which is really great and ideal for use kind of during that prodrome period when people may already have difficulty kind of taking a PO medication, that intranasal option is really, really helpful for a lot of folks. And then again, some of the other antiemetics that we're kind of all familiar with that can be used as well. Prophylactic therapies, I would say, by far and away, the one that has the most data is really the TCAs, and amitriptyline in particular has been the best studied. And so with efficacy of about 70% response in adults from retrospective studies. Topiramate, though, is another option. And also kind of based on very small retrospective studies, but the response rate has been up to 70, 80%. Coenzyme Q is actually another one that I've commonly recommended to patients. This has efficacy about 50% reduction in adults, and the dosing is usually about 150 to 300 milligrams per day. And the other nice thing about this is it's really well tolerated. It doesn't really have any of the side effects that we worry about with the TCAs or the topiramate. And aprepitant is another one that's oftentimes just really hard to get insurance approval just because it's an expensive medication. This is obviously not one of the indications for use, but something you could also consider in severe cases. I'll kind of skip upon this. So just want to touch upon cannabinoid hyperemesis syndrome, something that we're probably seeing increasingly, in the US and around the world. Also recently, I know the Biden administration is considering reclassifying cannabinoids or marijuana from Schedule I to Schedule III drug in the next year. So probably something that we may be seeing even more now. The cannabinoids are kind of a very heterogeneous type of medication. And so there's a lot of different chemicals that have been identified, and with over 100 cannabinoids as well. But while cannabis has been really well known for having antiemetic properties, more recently, it's been very well recognized now that really heavy chronic long-term use of cannabis has actually been associated with these cyclic episodes of nausea, vomiting, abdominal pain. So kind of very similar to how we diagnose cyclic vomiting syndrome. And again, that's more recent studies have seen a rise in both ED visits and as well as visits to GI clinics related to this problem. Diagnostic criteria is pretty much the same as that as cyclic vomiting syndrome, with the addition of there has to be this kind of history of, again, heavy chronic use of cannabis, typically over a year. And frequency, I would say most of the time it's daily use, but they say, at least 4 times per week on average. And it's kind of funny that this is part of the diagnostic criteria, but cessation of the cannabis leads to, resolution of the symptoms. But this, again, usually has to be a period of abstinence for about 6 months, or at least equal to total duration of 3 typical vomiting cycles for that particular patient. Some other supporting features, I think classically we all think of as that kind of compulsive hot, bathing in hot water that patients oftentimes report really relieves their symptoms, as well as exclusion of other common causes. I know I'm running out of time, so I just want to touch upon in terms of treatment. Classically, we think of in the ED, I think they're all familiar with this topical capsaicin. The reason why we think this works is because of the activation of the TRPV1 receptors. But there are other antiemetics that you can use. Really important, oftentimes patients get opiates, but this is really something you want to try to avoid. And then again, long-term management really is dependent on the cessation of cannabis, but there has actually been data to support the use of TCAs, again, in particular amitriptyline, which can be effective in about 70% of patients. So unfortunately, I don't think I have time to kind of talk about rumination syndrome, but just to kind of, end with some taking points here. So, I hope that I've kind of covered, how to make a diagnosis of gastroparesis and really, again, highlight the importance of both considering this appropriate symptomology, so having those cardinal symptoms, as well as some sort of objective measure or evidence of delayed gastric emptying. Kind of, again, thinking about gastroparesis, in particular mild cases of gastroparesis, being on a spectrum with functional dyspepsia, and kind of treating those cases similarly. Being selective of your therapy for management of gastroparesis, kind of based on the most bothersome symptom for that patient. Again, avoiding many of the mistakes and pitfalls that we see in taking care of these patients. And then again, recognizing some common conditions like cyclic vomiting syndrome, cannabis hyperemesis syndrome that can commonly mimic gastroparesis. All right. And so I know I'm kind of just on time, but happy to take any questions.